Another controversial yet relevant subject that has a huge impact on hospital costing is clinical variability. It is the impact of doctors' preferences and style of delivering care on the costs and therefore on profitability. Two different clinicians could treat a similar patient with similar conditions in widely different ways. This is an issue where costs are significantly altered only because of the physician's personal preferences, and it has absolutely no bearing on the outcomes. And this variation is large, it is persistent, it is difficult to measure, it's not talked about too much. And mind you, it has absolutely nothing to do with the patient's condition or safety. It is just plain doctor led idiosyncrasy. Clinical variation cannot be explained by professional uncertainty on care plans and outcomes, but basically because the behavioral styles and approaches of different clinicians can differ. One argument is that physicians behave either as cowboys, preference for aggressive medical interventions, or as comforters, preference for more conservative, rational actions. And, and based on their judgment, based on their behavior, different clinical scenarios and based on just these personalities, the clinical scenarios create different costs for exactly the same thing. And this basic style has a huge implication on outcomes and costs which are not measured or captured. Let's look into some practical examples to demonstrate this, and we'll come back to this again, clinical variability on costing. Here is a study that demonstrates the impact of clinical variability on costs. What you see on the slide is the variation in the average length of stay, ALOS, for doctors A through R in one department of an English teaching hospital which had patients of similar conditions with similar situations. And what you see here is that the average length of stay between Dr. A is 2.8 days, and then Dr. R is 6.6 days. The variation is almost 135%. Patient condition and preferences alone cannot explain this wide variability between these 18 doctors. It also, for sure, has something to do with the style of doctors. There is another milestone study that I want to draw your attention to in this area that was done by Dr. Kilich. Dr. Kilich looked at the costs of CABG, coronary artery bypass grafting. He compared these procedures across 633 hospitals that had performed isolated CABGs in 183,973 patients. Dr. Kilich found significant baseline variability in inpatient costs. All this was observed after a comprehensive risk adjustment. The average, and listen to this carefully, the average cost of providing the CABG procedure service at the hospital across the 633 hospitals, the average cost was $40,424. Guess what the standard deviation was? The standard deviation of the average cost between hospitals was 12,130. It's a 30% variation for almost similar procedure. And this was across a very large body of study, 183,000, almost 184,000 patients needing a similar isolated CABG procedure across 633 hospitals. This variation was due to a wide divergence in care pathways adopted by different surgeons to deliver care across these 633 hospital centers. Dr. Killich argues that there is an urgent need to examine these divergent pathways adopted by doctors as outcomes were similar, but the cost to the patient and the costs to the system were dramatically different. Please remember, high quality care with positive outcomes is the cornerstone of any hospital enterprise. However, we should not forget that these outcomes must also be delivered efficiently and cost effectively. Practice variation in costs due to doctors' personal preferences and idiosyncrasies has been adequately documented. It has been confirmed across several healthcare settings, and it cannot be explained by variation in patient illness or patient preferences. This variation is large, this variation is omnipresent, persistent, and very difficult to grasp. The fact that clinical variation exists is persistent, difficult to grasp, must be acknowledged by clinicians and our doctors. There's no way around it. Understanding this variability represents an opportunity for standardizing care and for improving resource utilization. Clinicians and especially surgeons must find a way to balancing lowering costs, decreasing variability, and improving outcomes. One possible way to address this is by training our clinicians on the practice of contemplative or reflective medicine, a deliberate and objective mindset that is strong on system 2, the deliberate thought process. If you remember one of the prescriptions that I had mentioned in earlier videos. And this focus on reflective medicine will probably make a doctor to consider one approach versus another, which allows for the system to reduce costs for the patient while keeping everything else the same in terms of outcomes, patient safety, etc. So you can see how different costing methodologies, clinical variabilities, lack of sophistication methods, it gives you a clue why most of the so-called cost control efforts in hospitals is generally an illusion. The savings somehow never seem to show up on the bottom line. So with that, we come to the end on the section on costing. I'll see you on the other side as we now talk about hospital pricing, where hospitals get away with murder. See you on the other side.